Welcome back to AI and My Doctor Part 2. We are delighted to start right into our panel discussions, AI-supported diagnosis, treatment, and the electronic health record. My name is Regina and I'm both honored and excited to lead you through this discussion. With us today on our virtual stage is again Professor Christian Lovis, Professor of Clinical Informatics at the University of Geneva, who already gave his presentation just in the previous session. And in alphabetical order, let me introduce our other guests. We have Dr. Balicer, Chief Innovation Officer at Israel's largest healthcare organization, Clalit, and founding director of the Clalit Research Institute. He's a public health physician. He has a PhD in healthcare management and also serves in advisory groups to the WHO. We have Dr. Markus Leyck, Dieken, medical doctor as well, who spends almost 20 years in the pharmaceutical industry, and he's here today as CEO of Gematik, Germany's national health infrastructure agency, where he is asked to deliver a secure digital health platform for Germany's healthcare system starting this January. And instead of the Danish Minister of Health, Magnus Heunicke, we have the pleasure to welcome Mrs. Nana Stufgaard, I hope that's correct to pronounce that, Head of Division at the Ministry of Health. She holds a master's degree in political science and has been a key player in developing the Danish Health Strategy 2018 to 2022. Welcome to all of us, to all of you. In a non-digital world, you would receive an applause and a welcome now. Instead, we are jumping right into the discussions and into your presentation, and we start with Dr. Balicer.
Hello, thank you so much. Good afternoon, esteemed colleagues, ladies and gentlemen. It is a great pleasure and privilege for me to be speaking with you today. What I will try to share with you in these brief 5 minutes is a view on what seems to be the next, I would say, forefront of digital health, which is predictive proactive care. And in this brief talk, I will try to talk both about some of the good aspects and the bright side, but I would also like to highlight one or two risks that are associated with this new and promising approach. Next slide, please. So the basic concept here talks about our ability to be able to see that something bad is about to happen to a person anytime in the future and not wait for them to come into our clinic and to provide them with care once they become symptomatic, but to do this early on, to avert them and to prevent the bad outcomes that are supposed to happen to them. Slide. So if I will give just one example, if you can move to the next slide, please. Yes, if I will give just one example, which I think is very telling, it is the case of end-stage renal disease. When a patient comes in and he has symptoms of a problem with his kidneys, that's usually very late, and there's very little we can do for him because the damage is already entrenched. Our only hope to make a true difference is to come when the patient feels well, looks well, but there's only the beginning of this very early signs and symptoms, and then we can make a tremendous impact with very low resources. And so in order to be able to identify the right patients that we want to intervene in on this very early stage, we need help. As physicians, as nurses, we have a challenging time finding them at the right place at the right time. And so this is where digital health, AI, and predictive analytics come to play. Slide, please. We can do this not only with the electronic medical record driven data, but we can do this more and more with the help of what we call the unstructured data. That's all the data that comes in from imaging, from pathology, from microscopy, and from various other sources, from texts. And all of this data, which has been traditionally more difficult to attain, now can be harnessed for this purpose of predictive proactive care and allow us to provide more precise, more predictive, more proactive approach in our medical practice. What I've just shown you before about this approach can be used in many different fields. And at Clalit, which is the organization I come from, which serves over half of the Israeli population, we have a data warehouse that houses data on over 4.5 million people for over 2 decades. And it's very diverse. It's data, it's inpatient and it's outpatient, and it's all of the measures as well of the clinical outcomes and the demographics. And all of this data is being used for us to produce these models, those predictive models, and then introduce the practice of bringing those predictions into the physician's office And so he can practice this proactive care. Slide, please. But not only bring it to the physician's office, and we do this for, preventing osteoporotic fractures, and we do this to prevent renal failure, to prevent stroke, to prevent diabetes, pre-diabetes, to turn into diabetes, and I can go to a whole longer list of things. We identify those flu patients that will have in this winter, that will have complications, and we try to approach them early and give them the vaccines. But what we do now is not only approach through the physician, but also direct to patient. We bring to the physician's handheld the prediction of what is future illness might look like, and how, if he changes something in his care, that could avert him from harm's way. Slide, please. And so we did this also in COVID, because in the COVID-19 event, we understood that we have to act very quickly. So we created predictive models in order to know which patients will be at highest risk of having a severe illness. Slide back, please. A severe illness. And we found those patients with the highest likelihood of severe illness, and we called them proactively home. And we said, stay home. Don't come to the clinics. If you have a problem, we'll give you digital care from afar. Please don't expose yourself to unneeded risk. And I think one of the reasons in Israel we have one of the lowest case fatality rates globally is partly because we had those high-risk patients, not only the elderly, but also younger age groups with multiple chronic morbidities. We made them stay home and averted them from the risk of COVID-19. Slide, please. So this makes sense clinically, but we also have been able to prove that it makes sense economically. So in one of our largest clinical trials, we approached those high-risk patients, those multi-morbid patients that are usually very resistant to care, and we were been able to actually reduce, using predictive proactive care, the hospitalization days by 43%, the readmissions by 55%, and this whole process of introducing specialized nurses to care for these highest risk patients was actually cost saving and was very effective. Next slide, please. Hit it again, please. And so there's something that I want to convey here, which is you don't always want to approach those at the highest risk. In many instances, you want to actually ignore the highest tier because they might not be amenable to change. They are not, their disease is intractable. So what we might be interested is actually, slide please, those middle tiers of risk, which are almost the highest, but they have the highest impactability. So this approach that takes two different measures, the predicted likelihood of the disease happening and the likelihood of an intervention being effective, is something that we have to use together in order to find the exact subset that is most amenable to treatment. And that's where you want to hit with your intervention and your scarce resources. So I think this is a very important concept, that this is what worked for us in many of our interventions so far. So this is something I wanted to share with you. Next slide, please. The one caveat, there's many caveats that we could talk about. We could talk about biases, and we could talk about fairness, and we've tried to tackle some of these in many different studies. But what I want to talk about now is the problem of overzealousness in approaching patients where the impact is not clear. And what we might see here is what we called choosing wisely on steroids. So choosing wisely is the concept that says that by overdoing, overdiagnosing, overtreatment, we might actually not benefit the patients, but actually cause them harm. And in an era where there's more and more data flowing in from sensors and from additional data points, it might be a little tempting for us to try to do all kinds of proactive care that do not eventually bring a benefit to the patient. So we really need to be very careful about this. And so we introduced this concept of sensoritis, which is saying, okay, sensors are nice. Everybody wants to put something under, something wearable, something on their hand, and to have lots of data coming in. But please be careful when we start hitting those patients too strongly. So my last slide and my last point is basically one that says that it is not a question of whether or not we should use AI in our daily practice. We have to. It is not a matter of the future care. It is a matter of the present. And very soon this will become a necessity to do some things with help. But this is not by any way replacing our work as nurses, as allied health professionals, and as physicians. But actually, this is only complementary. This will allow us more time. This will take away the repetitive components of our day jobs and will give us more time to do what we really wanted to do, what we really were trying to do, which is empathic, engaging care on our daily practice while using the benefits of those computational driven tools in order to provide insert and inject more accuracy and more proactiveness into our daily approach. Thank you very much for this time, and I'm looking forward to the rest of the panel. Thank you.
Thank you, Ran Balicer, and we move directly to our next guest, Dr. Markus Leyck.
So thank you so much to be present here now with the voice of Gematik, which is the National Digital Health Agency of Germany. And one can clearly say, first slide please, that EU on the Move is certainly the right title for a contribution that we bring from our side here, because we are now, as already mentioned by Dr. Vetters, we're just on the way to embark into a new era in Germany about the beginning of next year by introducing the first electronic health records into Germany. The word enabling here is the key word from a German perspective. Germany so far, and you that meet us on European soils know that very well, has for the time being been very seclusive, relying on its own little standards in own language, in own technical language, and has not been sending much of bridging signals to the other nations. This is certainly now the time where we are really going into a completely new era. We will be bridging. We will be sending collaboration signals. We will be certainly contributing to a European health data space. And we are strongly now having a clearly paced plan on how to embark onto this. Next slide, please. What you see here laid out is the steps that we are taking right now in the next upcoming years. You see here that we have already now a national platform called KIM to exchange data between the healthcare providers in Germany, where we'll ultimately have about 3 million healthcare providers, because it will include healthcare takers, physiotherapists, orthopedic shoemakers, and everybody else. And that is a very safe and secure platform, which is a national platform. And we all know that finally national level is the only secure way of digitalizing German healthcare sectors, which is very sectorized, as you may know, right? And then you see that we are now also, and the blue box really highlights that again, we are now embracing international standards. We're going into FHIR and other important standards. You know, Germany has already embarked onto SNOMED finally now. So we're now really using a language that will be able to be sustainable enough from a national perspective, and will be embarking for good collaboration within Europe. The pace is here that we will now bring the electronic health record, and then we will start to introduce new formats, new volume of data, and we will then have, probably by the third version of the electronic health record, what we call research, enabling electronic health record. And many of you have already commented on the need to have structured data. And I understand from my previous speaker that also unstructured data can be used in certain ways. But certainly right now you need data at least in languages and technical languages that are common and that can be used enough to allow the defined research that we want to ensure for academics throughout Europe with the population we have here at hand. So that is where the electronic health record is going. And it's also very important from an ethical standpoint, because we know that patients will never be submitted a broad consent. This is not what we see right now in the ethical debate about how patients consent in giving certain data points for certain research purposes. This will be certainly necessary to document very, very well for each citizen in Europe. What sort of data set is he donating to whom, under which auspices and which consent format, and hence, technically speaking, now Gematik is trying to make the electronic health record protocol each and every data set that has been looked at by physicians. We already have that in version number 1 now, but we will certainly be very, very distinctive about all the data structured points further ongoing, so that patients have a clear fundamental, trustworthy feeling when they say, okay, I want to set this data out for donation and I want to reserve others to be kept for myself. So easily spoken, but technically not as easy as it sounds, right? And then e-prescription is also something that Germany is finally catching up with you guys in Europe. We'll be nation number 18, I suppose, in the European continent now to provide citizens with the e-prescription mode, which we will then extend also to prescribing of all sorts of other material beyond pharmaceutical pre-made drugs into other support elements in the next years, which then will also go into the e-medication plan and obviously into the drug-drug interaction, which needs to be done digitally to a whole extent. And the good thing is that the infrastructure is really ramping up in the pharmacy sector. It's ramping up very strongly now in the physician sector, and the government has now given a strong financial boost also to the hospital sector to enable his competitiveness into this. And we are in strong talks with the hospital sector to ensure that the investments are now made into the right systems and not into someone which ends up a dead end road investment, and you don't want to go into the rear road. Here you want to have a forward-looking investment that is bridging and collaborative, right, on the European landscape, because we are also part of the International Patient Summary initiatives in Europe, and we will embark into introducing this as a cornerstone of the future electronic health record format. We hope that many of us will be seeing the valuable tools of this. And so on, where we also obviously now build our national contact point for e-health into the European community. Next slide, please. Now, the fundamentals that we are embarking on to ensure this good collaboration contribution of Germany to all of this is that we first need to do the technological leap. Germany's system so far on Gematik has been more than a decade old, and now in the next 2 years we will have to really take the leap. Just an example, from XL 509 to OpenID Connect. So EID will be distributed in Germany for all the citizens of Germany, so that they can use a federal EID system, a user-managed access approach will be part of this as well, so that we finally come up into a level that is satisfactory also from a user perspective and user experience perspective, so that all feel invited. Because ultimately, this is about inviting to create digital vitality in Germany. And therefore, we need what the number 2 here means is interoperability. That hasn't been the case so far, and we need a common platform in Germany of all clearly distinguished interoperability. And Gematik will now have the honor to host a roundtable about all the competent authorities and bodies to have clear conversations and decision-making about which standards at what time can we finally introduce to achieve international satisfactory interoperability, which then is hopefully setting the ground for a stadium where all these so far isolated digital offers can finally reconverge and find common languages, common technical standards to exchange their ideas and find their neighbors for their offering, so that we have a cross fertilization here. And that is what we believe will fundamentally be necessary to spiral the digital progress in any nation, which is not to be orchestrated by anybody. I think digitalization cannot be orchestrated. It can be regulated somewhere, but you really want the players to be able to inspire as much as they can and just rely on certain languages and technology platform, but then the rest comes by itself. Who would have guessed that our iPhones and smartphones one day have a microphone that is able to predict whether you will develop Parkinson's? Who would have guessed that the moving of our smartphones can tell something about the condition of elderly people and their detrimental ways when they move less? So all of this is the vitality of digital landscapes, which we want to enable by creating the stadium now finally in Germany with these common standards and platforms. And that also is the EU connectivity at the end, right? Because we are getting away from the very specific German standards into the European, into the international standards, because we know that Germany also can be enriched by many insights from other nations. We are very, very keen to see, for instance, the Nordic health registries, and there are many important insights to be able to be given right away to doctors and and patients and citizens in Germany about insights of, great population data that many other nations in Europe have to contribute, and that should be, given to all the European citizens so that they all get the best standard of care that is deducted from these very, very good tools that we see in many other nations around us here, right? And that brings us to the next slide, which is really the arena for digital health ecosystems. It is, that this exchange will invite many. We see already many now knocking our doors to say, okay, we want to contribute to this arena. How can we come into the same language standards to do this very well? And we hope that, we will be able to be bringing in a lot to the European landscape on that case. And last slide then is, I would kindly invite you then to really come and join one of the programs of the EU program of the government here, which is then focusing on, the digital health in the 21st century. What is ahead of us here? We will invite you guys to this conference if you'd like to see how we and the other national digital health agencies in Europe think about this, because it's getting very solid and setting now the grounds for embarking really into a decade of good progress for Europe in the digital arena. Thank you so much.
Thank you very much. And from catching up quickly to a country that's already highly digitized in its healthcare system and has a vast experience in electronic health record. We are curious to learn about that, and we are very happy to have Nana Skufgard here to tell us more about that.
First of all, thank you. It's an honor to be here on behalf of our Danish Minister of Health, Magnus. Thank you so much for the invitation, both to the German presidency, and thank you for the presentations already from Mr. Chiminski and Mr. Balicer. This really shows that it's an important forum to exchange ideas. I think the subject that we're discussing today is extremely important. It is so because the focus on data and digital solutions and technologies, what they can provide is important if we're going to provide better healthcare in the future for Europe. So, as you might know, Denmark is probably one of the most digitalized countries in the world. And as you might also know, we're probably one of the smallest. But nonetheless, this has created the basis for collecting data in a structured way that not many countries in the world can match. We sometimes call it a gold mine of data, but this only applies if we make use of the data correctly, safely, and with respect to the citizens' privacy. I think this is crucial. Trust is vital. The first goal of Danish healthcare digitalization is to support patients. For instance, patients who live with chronic disease. And the idea is then to use data so that they can take greater ownership of their own illness in their daily lives. Second, the goal is to use digitalization to fight inequalities in health, so that all citizens can get the best possible treatment, and not only those with more resources, that being intellectually or financially. And finally, a goal for digitalization, and I think also this is important, and Mr. Balicer also mentioned it, that digitalization and using data is really a tool to empower healthcare professionals into making better decisions in their everyday care. Digital tools should enable healthcare professionals to spend their time and energy where it is most needed, in valuable contact with patients. So taking away the waste time and really making time for the content. So from a Danish perspective, AI is part of the future and this story on how to use digital healthcare tools, both in diagnostics undertaken at the hospital and in diagnostics and treatment developed for outpatient care. For instance, AI is being developed in applications on phones to both diagnose and monitor skin disease. As mentioned, the things you can do with an iPhone is quite impressive. So AI is also being used in applications for psychiatric patients, and big data is being used in psychiatry to analyze large amounts of data to find relevant patterns, to explain connections that would previously be overlooked in these data. So it's a valuable input when it comes to treatment. And in Denmark, we now run a project to develop AI tools that can help general practitioners in their daily interaction with patients and to keep an overview and prioritize patients and patients' tests. So the idea is to take this relatively small amount of data that the general practitioners got, pilot with the other general practitioners' patients' data, and then swing it around to use it into making better decisions. And I noted that this probably might be the first of its kind in the world, but then I see Balicer, and I think maybe they've got something like this in Israel as well. But the idea is to use AI in daily practical treatment, for daily practical treatment purposes, and make it accessible for the general practitioners. So the question is, how do we collect data? Which data is needed? And how do we treat the data? Well, first of all, AI eats data for breakfast. And data need to be organized and fairly uniform, and there has to be plenty of it. So the data we collect in the Danish healthcare system, that's relatively easy. We define the data and we store them. And we have electronic patient journals. We think they're crucial. We've had them for years. And these systems form, you might say, the backbone of the Danish healthcare data collected and stored in both national and regional registries. But then there are the data collected from medical devices, apps, etc. And in AI perspective, where more data makes AI better, we cannot ignore that some of these data could hold some potential in complementing the existing, classic healthcare data. And it's what Mr. Balicer mentioned, that how can we make use of these unstructured data? In Denmark, a good example is we have a producer of incontinence products. So it's not classical healthcare products, but and he doesn't provide classical healthcare data, but nonetheless, his products are intelligent and they provide data. And he says to us, how I collect vast amount of data with my products, and what can I do with these data? How can I make use of them? We could use these data into providing better nursing home treatment for patients, for instance. But in Denmark, as of now, there is no legal framework for collecting and storing these data, and they do not exist in a uniform fashion that can be combined with our existing data. So we're looking into both legal and technical models to combine our classical data and these new types of data. And I think this is one of the topics that should be explored at a European level in the coming years. Second, we need trust in clear, transparent legal frameworks for both access and use of data. This naturally includes that the patient can control their own data, and that we also ensure that their data is protected against wrong use. In Denmark, as opposed to the German model, we do not operate with explicit consent from our patients, and all data from treatments are stored for later research purposes. And this is part of our collective responsibility to develop new treatments as a society, we think. And it ensures a structured collection of health data and solid base for research and also use of AI solutions. But it also puts a special responsibility on the authorities to protect their citizens' health data from wrong use. So therefore, when doing research on Danish health data, access is not just granted to data. Access is only granted to data when there is a specific legitimate purpose and that there is a public benefit to it. This is a crucial argument for the trust of our citizens. So, thirdly, we need to trust the applications themselves. We can support this by ensuring that applications and AI-based healthcare solutions are developed and certified within the European Union. So then we know that they're based on the common values we share in the Union when it comes to quality, privacy, and civil rights. So to further ensure the trust, AI-based technologies must be developed in close cooperation with our healthcare professionals. So the take-home message is this: we must ensure our citizens that we protect their data, strengthen the abilities of healthcare professionals to use digital tools and AI, and seek to improve the capacity to assess, validate, and certify AI-based healthcare technologies at the European level. This will benefit patients and healthcare systems, and it will support the European Union in becoming a leading region for developing and utilizing digital technologies and AI-based healthcare solutions. Thank you.
Thank you, Mrs. Skufgard. And I stay with you to follow up on a few of the points you raised. You said there is no legal framework in Denmark to collect data. Typically, healthcare is still a fairly national policy field. And now with Corona this morning, we heard a lot about collaboration across borders to work together. Is Corona now a chance to bring European health politics more closely together?
Well, definitely. My point was only that we don't have a legal framework to collect data from providers of new technological tools. There is no framework for me to, as a public care system, to access those data. But of course, we have a lot of data, classical healthcare data, that we collect at a national level, and that we can at least compare with in a European framework. And we can develop algorithms that we might combine with the data sets in our respective countries. So the point is not that I cannot collect the data, but it's taking the unstructured, privately generated data, like Mr. Balicer say, and then combine them with the classical healthcare data. In that, there's an issue that we might look into. Thank you.
Mm-hmm. Mr. Balicer, we in Europe, we also always look into the EU institutions to provide us with regulation. We are very proud that the GDPR is exported elsewhere. If you look at Israel, it looks from the outside that you take more standard, give some more freedom to competition. You do provide standards, but it's not as regulated as we are in the EU. What advice do you have for the European data space? How would you approach this?
I think that generally speaking, the steps that have been taken by the EU are very prudent and very appropriate to create a decent balance between our wish to harness the data for the good of the people and the health professionals on one hand, but maintain the need to maintain privacy and trust on the other. And these two things must remain all the time balanced. And I think that the EU is doing a very good job in trying to create this balance in accordance with the values, the core values that drive the EU. Israel had the benefit of putting very early on, from the early 90s, and in those times, those regulations were not put in place. So there was a whole lot of infrastructure that was already created, and we got ready-made when some of these international regulations were put into place. And we, of course, adopted all of these. So we now abide by the GDPR, by HIPAA, and by other standards that are internationally. But it's easy for us because, we now have all the data where we want it to be, and we have a good level of trust by the people that are very happy that they get predictive, proactive care on a daily basis, something that they know by now, that we keep their data very safe. Another point to put in place is that we have a very strong emphasis on cyber protection and protecting these data. So by no means we treat it lightheadedly. Actually, the cyber protection processes within the Israeli healthcare institutions are some of the most severe ones globally. And penetration tests and the likes and privacy maintenance are something that we do on an everyday basis to ascertain again and again that our data is kept in a safe way, but also that it's not rotten in those hordes of data, but it's actually brought to good practice to protect the patients and to promote their health.
Thank you. Christian, you said it's actually not a problem of the regulatory framework, but it's more the technology failed us in the pandemic. The regulatory measures helped to remove barriers, but technology didn't work. Why is that? Can you explain a bit on that?
Well, yes, maybe you saw the MIT edition of July, the MIT Tech Review. It was entitled "We Failed, MIT." So when you look at the details, there is a lot of discussion constantly about freeing the data in order to support AI, which is correct. There are a lot of barriers in usual times: privacy, patents, ownership. There are a lot of barriers. On one side, there are the people that want to save the world, and on the other side, there are people that want to save the individuals, which is not the same battle, as well said by Rand. It's hard to find a nice way in between. What happened during the COVID crisis and the pandemic is that in many countries there has been exceptional regulation, pandemic regulation that have been applied by the government, urgent ordinances that imposed obligation of transmission, obligation of documentation, obligation of everything. And for the governing bodies, is it public health, is it hospitals, is it prediction? As we here in Geneva, and you know it's a hot spot in COVID today in Europe, the hottest spot even, we have access to a lot of data. The problem is that because they don't comply to any interoperability standard, because they have a lot of problems at acquisition, because they have little metadata, because they are not well described, because a lot of reasons, despite the open barriers, so to say, no regulatory breaks, it's really hard to exploit these data to do something true, to take decisions in real time. So there is a lot of work to do in order to improve the metadata, the standards, the capacity to use this data and to use it in real time.
Mm-hmm. Dr. Dieken, interoperability is one of your key goals. Why is this so hard to achieve, and what infrastructure do we need for the secondary use of health data in Europe?
Yes, I think interoperability per se is not hard to achieve. It's just a matter of finally having a mandate and be able to decide wisely enough after having heard all the important voices to this. So this is, I think, why we will make a lot of territory in the next 2 years in the arena of interoperability. I think it comes from the fact that the initial solutions are always island solutions, and there is what some call the digital purgatory, the pilot purgatory, which is never surpassed by many digital pilots who never make it to a national level. And that is because they have reasons to decide for a certain technique, for certain technology that already exists in a certain hospital or in a certain industry. And so suddenly they step into an involvement and they love the baby, and so they lost interoperability. I think we're now on a very good way here to have a common ground in Germany to say we need national levels. We're away from any regional levels. We love the pilots, but we need the national levels. And interoperability now has enough competence in Germany and in Europe to be able to be decided clearly on, and we will embark on this. And then I think it will be a very vitalizing invitation to everybody to see that there is a nation that has common standards, and we're all going to use them to move forward.
Mm-hmm. If you don't have the benefit of already having historical data stored in your databases, you need the electronic health record to gather data. And we will look into some health records that already exist. Slide 1, please. What you see here is a picture of the Danish health record. It's a central platform not only for medical records, but also to book appointments, to get your prescription, to register for blood donations, to register for healthcare classes. And what you see here is it took a while for this to get accepted by the patients, and obviously I'm curious, what did it take to make this successful? What was needed to bring the numbers up? Ms. Gusgard. Do we have a voice?
Yeah, I do. Sorry. Technical issues. Well, I think, first of all, this is going back to 2012, and there had to be some content on the national healthcare portal. I think once there is content, be it from hospitals or from general practitioners, then people will go there. And if you inform them that their information is there, then they're interested and they will have a look. I actually, those slides we didn't provide them. And if you access the data on traffic now, it will be like doubled even further. And that's because if you get a COVID-19 test in Denmark now, that's an open offer for all people. You get access to test results within, now I think it's 33 hours. That's the medium waiting time. And you just enter your phone and your patient record, healthcare detail, and you get your test results. So all Danes, they know how to use this patient portal now. So I think it's just about making sure that the data that you provide are accurate and that you store them safely, like Mr. Rahn mentioned, and then provide some interesting facts for patients to go there, and then they will be interested. And of course, you have to take the discussion with your clinicians that your patients will now get access to information that are not necessarily explained to them. That has been a journey in Denmark. To begin with, we said, well, we cannot provide information for patients unless it's explained by their doctors. But now we said, if the information is there, we put it out for the patients and they decide for themselves whether they want to access it directly or whether they want to consult a clinician first. Thank you.
Thank you. Let's have a look also into Clalit app, and we see pictures here which you can access before you actually have to log in privately. So everyone can download it, have a look, and compared to the electronic health record we see in many European countries, the UX UI is colorful, it's playful, it targets younger generations as well. So how do you strike the balance between it's actually successful digital product and it's a serious medicine, safe place for data? Is that even something that's perceived for Israelis, or is it a German debate only, where you have an either or and here you combine it easily? Mr. Balicer?
I do think that the key for any digital product is usability and patient engagement. You can make something which seems very sophisticated and very appropriate, but if it is not enticing for the user, if it is not easy and intuitive to use, then you will have no usage in practice. And you have to be able to adapt your product to different subgroups of the population. It has to be culturally adapted, and it has to be language adapted, because you have to have it in multiple languages, and you have to adapt it to disabilities. Some people cannot see very well, so you need to have an option for them to see it in the larger text and easy and clear, understandable graphics. So I think that UI, user interface, and engagement are not only relevant for the gaming industry or for the retail industry. It is even more important for us in the healthcare, because eventually there's a smaller gratification at the end. We want them to do something that would have benefited them sometimes on the longer term, and there's no immediate benefit to them, and we still want to engage them. So I think that we need to adapt many of the methodologies, many of the sophistication that is being used by other industries, and we have to bring the experts from those domains to us to allow us to do more gamification and better user interfaces and more aspects in which we can entice our members to use it for the good causes, and not only to get them to spend money on a new Netflix movie or something to buy in Amazon. All of those methodologies have to be brought in, and we actually use them. I will mention one thing that we've done. We've actually used behavioral economics. We found out that our patients do not inform us before they miss an appointment, and we have a lot of no-show. So what we did, we used principles from health economics that allowed us to address our patients in different ways that approached various aspects of the way that their sentiments. And we were able, by using different SMS messages that were driven by an AI machine that adapted the right SMS message to the right patient, we were able to reduce no-shows by 30%. So it's a 30% reduction only by the use of the common sense that comes from other industries, just like behavioral economics, and harnessed into healthcare. And we should do more and more of this within our digital health platforms.
So, Mr. Leyck, Dieken, do we get a hotfix for nudging into the German EHR, or what do we learn from this if we look at these fairly mature solutions?
Yes, we're looking at all of them actually, and we agree that it needs a certain playfulness in digital to invite everybody to contribute very well. And we also need to make sure that people understand the scope of all this. If you talk about historical patient data, let me start with the most important one: the way you were born. The way you were born, we know already, predicts a lot in health. We know this from countries like China and Brazil, where cesarean and naturally born babies have a very high percentage. And we know that that already is a predictor, or at least, an inclination to certain diseases. And then it goes on with, have you been, given, mother's milk, or have you not? And so on and so forth. So the dimensions of health that we can open up to bring to the debate and make conscious to all of it, each and every citizen in Germany, is tremendously large. And as good as our healthcare systems are nowadays, we also need to admit, and I say this as a doctor myself, there's a lot of untapped territory. I would say there's so much unknown in medicine as there is oceans on this globe. And we in medicine sometimes have cover words to kind of hide the fact that we don't know where the disease comes from, or that we don't have any given clear therapy for that. And there's enough burden of disease still that needs those clarifications. And I think people more and more understand that only their contribution to community will be a balance between themselves winning and community winning. And I think that's something where other societies have progressed very strongly. The Nordic consensus is certainly a role model in that case. And I also hear Nana saying that there is an opt-out and less an opt-in solution in many of their elements, which is something to be taken up repetitively into the democratic debate in Germany as well. And so people will more and more understand that, yes, there is a lot to win, much more than they believe by just looking at the imminent treatment of the next 4 weeks of their disease, if they bring in such data points of their historical life. Because look at autoimmune diseases. If you have a child that has diabetes type 1 and is 7 years old, we are all aware that that has started probably 5 years ago. Now, what was in this baby's life 5 years ago is what we need to look at and discover. And an electronic health record can do such things. So there's actually good motivation for everybody to use an electronic health record from very early on in life to elucidate more and more for himself and for the community.
Chris Jones, physicians also need to get used to big data and gain trust into their new AI colleagues. How do we make them a partner in this?
It's an important point. We started here in Geneva 2 years ago to teach our young students AI and big data, data literacy, but also what is AI? To leave the magic of AI because at the end, AI is like a pregnancy test. It has a positive and a negative predictive value. It is used in a certain context. It's nothing different than a pregnancy test. It is like anything else in Bayesian world, but we have to be very careful not to build a fracture between people building systems and people using systems, especially in this field. And currently, we see that it is very important to do this move towards teaching everybody early. If you think about physicians, they will be on the market, so to say, in 10 years. How will the market be for AI in 10 years? Very different than what we have today. So we have to start now, not only building systems, but making sure that the drivers are able to drive the cars.
Mrs. Skufgard, how do you enable the drivers to help them driving cars? You said that you're now in the next step to integrate big data and integrate pathways for chronic diseases into the health record. That also would include that the general practitioners need to know how to include that into their day-to-day work. How do you take them along this way?
First of all, I really think that the whole issue of digital competences, and this is both about how do we teach healthcare personnel to work with digital solutions and have a patient contact using these new technologies. And it's also about entering new types of professionals into the whole arena of providing healthcare, like engineers, etc. So I think this is a very important area. If we really want to work with new technologies, we have to work with digital competences and a digitally competent workforce in order to get them on board on the journey. And I think if people understand, if technologies are relatively intuitive and easy to use and fun to use, like Mr. Ran mentioned, and that it is clear for people, for healthcare professionals, that this can make a positive difference in the way they treat their patients, then usually they are on board. They should feel secure. I know what to do, and I know that this is a positive difference for me in my treatment. Then we can get nurses and doctors, etc., on board. In Denmark, one of the registrations is that it's sometimes easier to get nurses to use new technology than it is to get the physicians to use new technology. And that has got something to do with the power and balance and comfort zones, I think. But if we really work with this issue of digital competences, I think we can get a long way. And so digital competences also relate to the idea that that physicians should be safe. Well, they should be sure that the tools they are using are safe. So that brings us back to the whole idea of having certificates, and that you are sure that the tools you're using, that they are safe, that you can trust that the data they provide, that they are validated. So they should be easy to use and secure to use, both from a technology perspective and from a data use perspective. I think that's important. But does that somehow answer your question, or tap into the discussion?
That resonates a lot, thank you. Digital competence is also part of the patient if they have to donate their data. Markus, like Dieken, that's the scheme our policymakers come up with, because if the patient is a sovereign of his or her own data, he or she has to donate those data to give them to research. How do you explain this? Isn't this something where you have to educate a lot before you get there?
Yeah, I think the electronic health record already now tells everybody that they can decide of how long a physician can even look into the data. He can give it 1 day at the spot of the clinic, or they can give it a whole year. And they also see which document was ever opened. So already now we have some protocol level. Now the data will go to a neutral body in Germany, right? Something like we would maybe compare that with a notary, right? I think the trustworthy is exactly like Nana described in Denmark. Do I, as a citizen, believe that my data are firstly securely collected and that they're only given out as I is consented to, in enough given good reason by someone who approaches such a body, which we need to establish in Germany, and I understand that will be established in Germany very soon, so that I have trust into that notary function here, that my data will be only given if there's enough substantialized reason to do credible fundamental research with this. And that needs to be given into the debate and needs to be publicly discussed sufficiently well, so that people really understand the broadness of the trust they can have into the system here in this case, right? And Gematik certainly stands for trying to secure your data in a level that is as high as we can bring it under current technical landscapes, so that people really have a reliability to step into this world.
Mm-hmm. Mr. Balicer, you probably have the greatest depth of already diving into the data. Are there any findings? Have you had projects where you said, this is surprising for me as a medical doctor? There's something AI found out which I wouldn't have assumed as a doctor, but AI really helped me to find something.
Yeah, I think we have numerous such examples that have been surprising. And when you do these types of analytics, there's two types that you do. One, which is a more detailed understanding of each and every feature's impact on the outcome, and one which is more of a black box, where you drop everything into one big machine, and and then you grind it all together, and you get at the end a product which is predictive. When you do the first methodology, or when we try to use white boxes to kind of look at what's behind the work of the black box, you find interesting things. Let me give you one example. In one of our osteoporosis fracture prevention programs, we fed a lot of different variables into our models, and it came out that eye disease was very, very strongly associated with the outcome. Now, I went to med school, and I don't know of anything that links eye disease with osteoporosis, okay? And so this was a great surprise for us, and maybe there's a new mechanism here. But only after a while, we got it. You know, it's not that eye diseases are associated with osteoporosis. Those who have eye diseases don't see well. Those who do not see well, they fall. And those who fall, they break. So it wasn't about the association between the eye disease and the osteoporosis. It was about the fact that those with eye disease just tended to fall more and manifest kind of with fracture their basic osteoporotic problem. So, and there are many other examples in which we've identified subgroups of patients at risk with which we never thought that would be of risk, and vice versa. When we started looking at the risk of morbidity or severe disease with COVID-19, we were absolutely sure, just like in influenza, asthma would be very important as a risk factor. And very immediately, our basic model said, it gives no benefit to the overall model. And so we understood that, this might not be just your classic respiratory illness with its usual risk groups. There's something else that's going on here. And later on, evidence only kept on making this point stronger and stronger. So yes, I do think that there are in many instances some and sometimes we don't even know. The decision is being made, and it's very difficult for us to trace back and understand exactly what is the exact combination of different factors that made this person to be more susceptible than the other one. But, by testing and retesting, by using the classic training, test, and validation sets, you were able to say whether or not this was only circumstantial, or that this is something that has a causal mechanism that will be sustainable for the rest of the usage of this model.
Great example on how AI can lead to new conclusions, can think differently, and we will have more of these examples in the future. I thank all the 4 panelists for this interesting discussions. We will go into a break now, and you can join and rejoin the discussions at 2 p.m. Thank you.